First, the team leader directs an assistant to check for responsiveness using a tap and shout. The patient does not respond to taps and shouts, and it's at this time that you would want to call a code or ask for additional help depending on your area of practice. The code is called and the team is on their way. Now, we want to assess for a carotid pulse and for breathing as we begin gathering appropriate equipment that may already be in the room or close by. As we check for a carotid pulse and breathing, we find no pulse and the patient is not breathing. It's at this time that we would want to place a CPR board under the patient, or if it's in a hospital bed with a CPR button, activate it so that the bed will deflate and make the surface as rigid as possible. It's at this time that CPR is initiated. And as additional assistance or the code team arrives, we're able to direct each of the team members to their respective roles or be assigned roles if all are equally trained. Please prepare a basic airway adjunct and ventilate with 100% oxygen delivered via bag valve mask at 12 breaths per minute is a good example of how that may sound. Now is a good time to begin thinking about an advanced airway if protecting the airway or if oxygenation with the basic airway is insufficient. To obtain 100% oxygenation, we will need to turn the oxygen regulator at 15 liters per minute and allow the bag valve mask reservoir to fill prior to ventilations being delivered. At this time, the leader calls everyone to stand clear while analyzing the rhythm. We then see that the patient is in what looks to be asystole. At this time, the team leader states, let's keep giving high-quality CPR. Because there isn't a shockable rhythm now, we move to the IV access or an IO access in order to begin medication and fluid therapy. In our scenario, an 18-gauge antecubital IV is established. At this time, the team leader should call for 1 milligram epinephrine, 1 to 10,000 to be delivered IV push and then flushed with 20 cc's of normal saline. This ensures that the medication is in the central circulatory system. Remember, CPR should still be in progress and should not be stopped for the delivery of medications. After CPR has been in progress for some time, the recorder says about 2 minutes has gone by. It's at this time that the compressor should be switched with the monitor defibrillator. Now would be a good time to do a quick look at the monitor for changes. This should not take any longer than 10 seconds before the shock is delivered or CPR is resumed if there is no change in the rhythm. The team leader states it appears the patient is still in asystole, so let's continue with CPR. Now's a good time to consider an advanced airway. The team leader states, let's prepare for intubation and attach capnography. Tube placement is accurate and lung sounds are equal and good bilaterally. Air in the stomach sounds are negative. The team leader states CPR quality looks good. Let's ensure we're monitoring capnography. As CPR has been in progress for a while, the recorder states that it's been about 4 minutes since epi was first given. The team leader should now call for a second dose of epi, 1 milligram, 1 to 10,000 IV push, flushed with 20 cc's normal saline. Remember to change compressors every 2 minutes or upon noticeable fatigue to ensure adequate CPR compressions throughout the whole code. Once initial treatments have been started, it's important to ask the team to help in considering why this patient went into asystole. To do this, we should consider the reversible H's and T's. Asystole represents what is termed to be final rhythm. In other words, cardiac function and electrical activity have diminished over time until there's no perceivable electric or mechanical activity and the patient biologically or is permanently dead. Unless there are special circumstances like hypothermia or drug overdose, prolonged resuscitation efforts beyond 20 minutes are usually unnecessary and futile. The team leader may consider stopping resuscitation if the ET-CO2 is less than 10 after 20 minutes of high-quality CPR and all treatments have been exhausted.